Steve, you think we ought to try to turn this light off up front maybe? Yeah, it's going to be better. Well, thank you. We can't talk about cholesterol and how to manage cholesterol unless we talk about cardiovascular risk and how to assess cardiovascular risk, because the decisions about treatment depend not just on your blood level of cholesterol, it depends much more on what your total risk of having a heart attack or stroke is. And that's going to depend on your age, your sex, your blood pressure, your cholesterol, a variety of factors. But that's one of the changes in the last few years. So let's look at this. So why are we concerned about atherosclerotic cardiovascular disease, that is heart attacks and strokes in the United States? Well, 15 million people live now with coronary heart disease in the United States. 6.6 million live with a stroke. And right now, somebody has an acute coronary syndrome, a heart attack or near heart attack, every 34 seconds in the United States, and they die from that every 84 seconds. Strokes occur in patients about every 40 seconds in this country, and stroke deaths about every 240 seconds. All of this translates to the fact that 65% of the men in this room will have a myocardial infarction and or stroke. 53% of the women will, and a third of us will die from either myocardial infarction or stroke. And this is the major cost factor in the United States. It's $100 billion a year. So it is a big deal. Well, what states are the worst in terms of atherosclerotic cardiovascular disease? You can see that states in the South have more heart deaths per 100,000 population per year than states in the Rocky Mountain West, although the healthiest state in the United States in terms of heart disease is actually Minnesota. Utah's pretty close, and we're about the same level as Utah. But people in the South are not eating the right stuff, and they have the wrong gene pool. What about modifiable cardiovascular risk factors in the United States, meaning we can do something to change those risk factors? Well, if you look at the population age 45 to 79, you can see that high cholesterol and hypertension are present in nearly half of us, obesity in over a third of us, smoking less in Utah than in the United States in general. But 82% of us, roughly 80% of us in the United States have at least one modifiable cardiovascular risk factor that needs to be addressed. There are other risk factors besides the major ones. We now know that inflammatory joint diseases, rheumatoid arthritis, lupus, chronic HIV infection, these are also risk factors for having atherosclerotic cardiovascular disease. Well, if we got after those cardiovascular risk factors and we treated them either with diet or medication or both, and we eliminated those cardiovascular risk factors, how well would it work? If we eliminated all cardiovascular risk factors, you can see that we would cut heart attacks and strokes by at least 50% and maybe more. Smoking and hypertension are probably the two most important cardiovascular risk factors to get after. High cholesterol, that we're going to talk about today, still important, although questionably less important in women. And diabetes and obesity are the other ones that we need to get after. But if we got rid of everything, we could cut the risk of heart attack and stroke by half or more. So there's some key messages that we ought to think about today as we go through this. Heart attack and stroke are most often caused by combinations of mildly elevated risk factors. A little bit of blood pressure, a little bit of cholesterol, a little bit of smoking, a little bit of diabetes. That's much more common to cause heart attack and stroke than a really high cholesterol or a really high blood pressure by itself. And so we have to look after all of the risk factors. So when we look at all of those risk factors, the way we approach things now is we try to calculate a patient's 10-year risk of having a heart attack or stroke, and also calculate in younger patients the patient's lifetime risk of heart attack and stroke based on that risk factor profile. And if we're going to prevent heart attacks and strokes, we have to treat all of the risk factors simultaneously, not just one. We have to get after them all. Everybody should be doing lifestyle modification, and we'll talk about lifestyle modification for cholesterol today. Drug therapy for many patients. And where the controversy has been is at what level of risk should people be on drugs to lower cholesterol? How high a risk is enough? So, how do we do that cardiovascular risk assessment in the office when we see patients? The first thing is we look at irreversible risk factors that we can't deal with. Older patients have more heart disease than younger persons. We can't deal with that. Men have more than women. We can't deal with that. Blacks, people of South Asian descent, and Native Americans have more vascular disease than whites, than people of East Asian descent or Hispanic descent. Your family history is important, but it's only important under certain circumstances. If you have a first-degree male relative under age 55, and first degree means your father or your brother, and they've had a myocardial infarction or stroke, that doubles your risk beyond anything else. For women, if you have a first-degree relative, a mother or a sister under age 65, it doubles your risk. But if those parents and brothers and sisters are older than 55 as men or older than 65 as women and had a heart attack or stroke, it actually doesn't change your risk at all. It's only when it occurs at a young age. But there are also modifiable risk factors that we need to consider. We're going to look at cholesterol. Higher is worse. We're going to look at HDL, the so-called good cholesterol, where lower is worse. We're going to look at your systolic blood pressure, whether or not you're treated for high blood pressure, whether you smoke, whether you have diabetes. And we're going to put all of those risk factors into an equation to try to calculate your 10-year and your lifetime risk of having a heart attack or stroke. How often should you get your risk factors assessed? It's currently recommended that everybody have their risk factors assessed beginning at age 20. After that, it depends on what your risk factors are like. If your risk factors are optimal and your calculated 10-year and lifetime risks are low, you only need to check all these risk factors every 5 years. But on the other hand, if your risk is not optimal and your risk factors are not controlled, then depending on how bad they are, we might recheck that assessment every 1, 2, 3, or 4 years. So how do we do the calculation? How do we combine all of these risk factors to determine your 10-year risk of heart attack and stroke? What most of us use over the last 3 years is what is called the pooled cohort equation, which was designed by the American College of Cardiology and the American Heart Association based on studies in a couple of 100,000 patients in the United States. You can go to the website here, and if you have your own blood pressure and cholesterol values, you can plug those in on the website and actually see where you stand. So when you go to the pooled cohort equation website, this is what pulls up. And so you're going to see the risk factor list here, and you're going to put in male or female, you're going to put in your age, you're going to put in your race, and the only two races that are considered are African American and white. If you are of East Asian descent, we suggest that you put in the white calculator. If you are of South Asian descent, we suggest you put in the African American calculation. You put in your total cholesterol. You put in the level of the HDL or good cholesterol. You put in what your systolic or top number blood pressure is. whether you're treated for high blood pressure or diabetes, and whether you smoke. And what comes out is your 10-year risk of a heart attack and stroke. And for this particular person, that was about 15%. And your lifetime risk, which for this particular person came out at about 50%. And then you can look at the graph that compares what your risk is to somebody who has optimal risk factors. And so you can see that if you had optimal risk factors, your lifetime risk would only be about 6%, and your 10-year risk would only be about 1.7%. So you can make that calculation, and your physicians and clinicians can also make that calculation based on your overall risk factor set. Well, let's look specifically at the cholesterol stuff. Cholesterol is made up of different components. Total cholesterol, very important. The higher it is, the higher risk you have of heart attack and stroke. More important than total cholesterol is the LDL cholesterol, the so-called bad cholesterol. We know that higher LDL cholesterol increases your risk of heart attack and stroke, and we know from studies in several 100,000 patients that lowering LDL cholesterol will lower your risk of a heart attack and stroke. HDL is the good cholesterol. We know that when that is low, it increases your risk of heart attack and stroke. But unfortunately, all the studies have shown that raising your HDL cholesterol does not do anything to change your risk. It doesn't make your risk of a heart attack and stroke any better. What about triglycerides? Triglycerides are a source of controversy. And higher triglycerides might increase your risk of heart attack and stroke. We're not 100% sure. But thus far, the studies show that lowering your triglycerides does not reduce your risk of heart attack and stroke. So our focus nowadays is on the LDL cholesterol, the bad cholesterol fraction. That's what we focus on. So, total cholesterol increases mortality as it goes up, and you could plug in LDL cholesterol and it would be an even steeper line. This graph shows the risk of having heart attacks and strokes according to your level of cholesterol on the things for different age groups of patients. And you can see that in any age group of patients, as your cholesterol goes up, either your total or your LDL, your risk of a heart attack and stroke goes up dramatically. So, how should you get your lipid tests measured? We used to think that people needed to do a 10-hour fast before they had their lipids measured. And that often meant that patients had to come back to the office. It was a gigantic hassle, and they often did not come back. But it turns out recent studies show there is minimal, unimportant difference between fasting and non-fasting lipids. You don't need to do that 10-hour fast. Your doctor, if you go in the afternoon and you had lunch, you can still have those lipids measured. The only exception is if you have one of the uncommon triglyceride disorders, then you would need to come in fasting. But otherwise, it doesn't matter. The other thing that you should know is that lipid levels vary over time spontaneously much more than you would guess. Some of that is due to simple laboratory variability. Some is due to biologic changes. And so your clinicians ought to be basing treatment decisions on the average of at least 2 cholesterol profiles before anything is done, because it can change things. Well, how can we lower the bad LDL cholesterol? All of us would like to do it without medication, and it turns out, unfortunately, that doesn't work very well. If you stick to what is called the NCEP, or National Cholesterol Education Program Step 2 diet, which is less than 7% saturated fat and less than 200 milligrams of cholesterol, if you decrease the foods that are known to increase LDL cholesterol, and you do it with great vigor, you can only cut your LDL cholesterol by about 7%. That's not totally worthwhile, or not worthwhile, but it's not great. But a new dietary approach is called the diet portfolio, and it's just the opposite approach. This is to add certain foods that we know lower LDL cholesterol, and I'll show you those foods a little bit later. In studies where they gave the patients all the foods to eat for 6 weeks, they were able to lower LDL cholesterol 30%, which is as good as a statin drug. Well, nobody's going to provide us all our foods. They did another study where they had the patient see the dietitian 2 times for about a total of about 2 hours and go through what kind of foods to add. This was able to lower LDL cholesterol about 13%, much better than that 7%. And so what we try to do now is to decrease those foods that increase LDL cholesterol and add some foods that will decrease it. And we'll look at some more detail of that. But the drugs are way better. Statin drugs at what we call a moderate dose, depending on the patient, because there's some variability from patient to patient, a moderate dose of any of the statin drugs will lower your LDL cholesterol by 30 to 49%. That's way more than the diet's ever going to do. High doses that we use in patients who already have vascular disease will lower your LDL cholesterol 50 to 55%. So the medications are very different than the diet. There are a new class of drugs that just have come out in the United States, okayed by the FDA about 6 months ago. These are called the PCSK9 inhibitor drugs. This is an injection. These drugs lower your cholesterol by more than 70%, but they cost $15,000 a year. So that's a lot, and the insurance companies ain't big on picking that one up. Well, how good are statins to reduce cardiovascular events? That's really where the action is. Regardless of how much they lower cholesterol, how much do they actually lower cardiovascular events? We have a huge database, 27 randomized trials that compared statins against placebo, 175,000 patients. In these studies, 100,000 of the patients had existing vascular disease, heart attacks or strokes. About 70,000 patients were otherwise healthy. They hadn't had any prior vascular disease or strokes. And lowering LDL cholesterol by 40 points, by 40 milligram %, reduced cardiovascular events, heart attack and stroke, by 1/4. But we know that moderate dose statins will lower LDL cholesterol more than 40 milligram %, and they will lower cardiovascular events at least 30%. And high dose statins will lower cardiovascular events by 45%. Dose matters. Of great interest and importance is no matter what your baseline LDL cholesterol is, whether it's less than 80, whether it's 80 to 100, whether it's 100 to 120, whether it's over 140, at all baseline levels of LDL cholesterol, statins reduce the cardiovascular events about 20 to 25% for each 40 milligram % reduction. So what matters here is not so much what your LDL cholesterol is, it's what your level of cardiovascular risk is. You can have a great cholesterol, but if your cardiovascular risk is high, you still ought to be on a statin medication because it's still going to cut your overall risk by 20% for each 40 milligram % reduction. It's not the level that counts, it's the total risk that you have. Well, what are the benefits from statin therapy in the United States? The one data we have comes from the National Health and Nutrition Examination Survey. They looked at data from 2008, at which time 35 million Americans were on statins. When they looked at these patients, they found that the mean reduction in LDL cholesterol on a statin was only 22 milligram %. and we could actually get it down 60 or 70. So why was there such a low level, do you think? Such a low level of reduction, just 22 mg%? Patients don't take their medications. That's exactly what this is patients don't take their medications regularly. But even with this low reduction of 22 mg%, statins in 2008 prevented 61,000 myocardial infarctions, heart attacks, 22,000 strokes, and 40,000 deaths. And they saved the country $5 billion, despite the fact that a lot of the patients weren't actually taking their meds very well. So, the big question is, who should be treated with a statin? And we base that not on your level of cholesterol, we base it on your 10-year and lifetime risk of a heart attack and stroke. Everybody internationally and nationally agrees that if you have a 20% or higher 10-year risk of a heart attack and stroke, you ought to be on a statin drug. Everybody agrees. Who has such a risk that high? Well, if you already have vascular disease, if you have coronary artery disease, if you've had a stroke or mini stroke, if you have peripheral artery disease in your legs, you have a greater than 20% 10-year risk. Who else has a greater than 20% 10-year risk? We don't see LDL cholesterol levels of 190 and higher very often. And when we do, this most often is not determined by your diet, it is determined by bad genetics. And most of these patients have positive family histories of early heart disease, and almost all of these patients will have a 20% 10-year risk or higher. So we're going to also recommend statins for all of those patients. The third group are people who have diabetes. If you have diabetes and you're a male between the age of 40 and 75, your risk of a heart attack and stroke is twice the risk of your cohorts who don't have diabetes. If you are a woman age 40 to 75, your risk of a heart attack and stroke is 4 times higher than if you didn't have diabetes. So for all of these groups, statins are recommended right off the bat, regardless of your level of LDL cholesterol. What about the general population? And that's probably most people in this room, age 40 to 75, who don't have vascular disease so far, who don't have diabetes so far, and their LDL cholesterols are not over 190. What do we do for those patients? Well, here there is a little bit of controversy about the threshold to recommend a statin. The United States Preventive Services Task Force makes recommendations to the federal government about what the federal government ought to pay for in terms of Medicare. And they suggest that if your 10-year risk for a heart attack and stroke is 10% or higher after you've been on diet and lifestyle modification, that you ought to be on a statin. The American College of Cardiology and the American Heart Association are more vigorous. They suggest if your 10-year risk for a heart attack and stroke calculates out to be 7.5% or higher, you ought to be on a statin. And if it's 5 to 7.49%, you ought to be thinking about it, particularly if your LDL cholesterol is 160 or higher, or if when you calculated your lifetime risk it was over 30%, or if you've got that family history of early vascular disease, men under 55, women under 65, parents, brothers or sisters, or if you have managed to have a calcium score, a coronary calcium score, which I don't personally recommend for very many patients, and found it to be high. So they suggest that all of these patients are on statin drugs. So, what statin drugs? There's a whole boatload of them. We know that moderate intensity statin drugs will lower your LDL cholesterol by somewhere between 30 and 49%. It varies from patient to patient, and it will cut your risk of cardiovascular disease by about 30%. High-intensity statins will cut your LDL cholesterol by over 50% and cut your cardiovascular risk by about 45%, almost cut it in half. So what are the moderate and high-intensity statin doses? There are only 2 drugs on the market that will lower your LDL cholesterol by 50%. And that is 20 to 40 milligrams a day of rosuvastatin. This is Crestor from the television ads. 40 to 80 milligrams of atorvastatin. This is Lipitor from the cardiovascular ads. But notice that rosuvastatin and atorvastatin at lower doses will reduce your cholesterol by a moderate degree. Notice that simvastatin, that a lot of people are on, pravastatin, lovastatin, fluvastatin, pitavastatin, there are no high doses that will, high intensity that will lower you 50%. And so all of these drugs are fine. You just have to decide, do I need a high intensity because I'm at high risk, or do I need a moderate intensity because I'm at moderate things? Does everybody respond to a statin? They don't. About 4% of the population has no reduction in LDL cholesterol. 4 out of 100 people will have no reduction in LDL cholesterol, even when they're taking that statin with great faithfulness. About 10% of the population do not get these 30 to 49% or 50% reductions, even if they're taking the medication. So about 15% of the population don't respond to statins quite as well as we would like. Well, everybody's worried about statin toxicity. And so let's talk about statin toxicity, and let's first talk about the concept, do statins cause liver injury? If you go on the internet, that's what you're going to see. We know that statins can bounce your liver function blood tests up a little bit in a very small percentage of patients, but it always goes back to normal when you repeat it, and it doesn't cause any liver damage. We know that actually getting hepatitis that makes you symptomatic is 1 in 100,000 with a statin drug. And we know that liver failure is no more common with a statin than it is with placebo. It's 2 in a million. These increases in liver function blood tests get better in almost every single patient. Significant liver injury is very rare. I've never seen it since statins came out in 1989. And the Federal Drug Administration, beginning in 2012, says because the risk of liver disease is so low, there is no reason anymore to monitor liver function blood tests when you go on to a statin. Because what happens is you pick up these asymptomatic increases, the patients get all excited, and they go away and they quit taking their statins that they actually need. What about diabetes? Do statins cause diabetes? And the answer is yes, but it's very, very uncommon. 13 trials with 91,000 patients who were followed on statins for 4 years found that for new diabetes cases, it was 4.9% of the people on a statin developed new diabetes, 4.5% on placebo developed new diabetes. This was primarily with the high doses of the statins as opposed to the moderate doses of the statin. And almost all of the cases of new diabetes were in people who already had multiple risk factors for diabetes. And in the end, all that the statins did is they provided a diagnosis of diabetes 2 to 4 months earlier than if you were on placebo. If you put all this data together and you were to treat 255 patients for 4 years with a statin drug, you would prevent 5.5 heart attacks and strokes while you caused 1 case of diabetes. And most of us think that's a pretty good ratio. Cognitive dysfunction. Do statins screw up your thinking? Well, the FDA got a bunch of patients who wrote in letters, and this is where this data comes from. They wrote in letters that said when they went onto a statin, they had memory loss and confusion. I see these patients every single day in my clinic, and they're not on statins. This is the #1 complaint that I get. So the New York Times picked up on this and had an editorial, "A heart helper may come at a price for the brain." This didn't help us any. What do the studies show? Because it's been studied very carefully. 14 studies with 27,000 patients did detailed cognitive testing in patients on statins and in patients on placebo. There were no adverse effects of statins. 8 studies with 23,000 patients found that statins reduced the risk for dementia, reduced it by 29%. A systematic review of 800,000 patients found that statins reduced the risk of dementia by 21%. So do statins cause cognitive dysfunction? The answer is no, they don't. There is no evidence that these drugs cause short or long-term cognitive dysfunction, and there are suggestions that maybe they reduce dementia. The big problem with statins, though, is muscle pain. And this is a real problem. In the randomized trials, when they looked at muscle symptoms and muscle enzymes, they found that muscle symptoms were no more common with statins than with placebo, and that severe muscle injury was very, very rare and not different from placebo. But it turns out the randomized trials had some problems. And the problems they had is they all had run-in periods. And what a run-in period means is that you recruit a patient for the study, you give them a statin drug, and if they get muscle pain, you kick them out. And so right away, the randomized trials are a little biased. So if you look at observational studies, not randomized, no placebos, depending on the study, muscle symptoms occur with statins anywhere from 7 to 29% of the time. However, a lot of these muscle symptoms, we would be suspicious, come from working out in your yard or something else. So what we really need is a randomized trial. And I think this trial tells me about statin muscle pain. They took 420 patients who'd never been on a statin before, and they randomized them to the maximal dose of Lipitor, 80 milligrams a day, or they gave them placebo. And neither the clinicians nor the patients knew who was getting what. And they followed these patients for 6 months for muscle symptoms and for a whole bunch of muscle function tests, strength, electromyograms, all kinds of stuff. And what they found was that about 9.4% of the patients getting a statin had some muscle symptoms compared to 4.6% without. So I read this as that 5 out of 100 patients probably get true muscle pain from statin drugs. 5% of the patients get muscle pain from placebos. So do statins cause muscle pain? They do, maybe 5 in 100. In people who have had statin muscle pain, they have done what are called re-challenge studies. They have the patients stop the statins. They then give a different statin, maybe at a lower dose, or they give the patients placebo. And what they find is that when they do that, somewhere between 70 and 90% of patients will tolerate the statin with no muscle pain. Are there patients who get muscle pain with every statin? There are. They're not common. So how do we minimize statin muscle symptoms? What we tell our patients is if they need to be on the statin, the cardiovascular benefits of these drugs are enormous, not to be ignored. We tell patients, be sure your muscle symptoms are not due to some other activity that you just did. Don't talk yourself into it. If you have low thyroid function or very, very low vitamin D levels, it probably increases statin muscle pain. So we frequently will check these before we start. We know that 3 of the drugs have less muscle issues, less muscle pain. So rosuvastatin, pravastatin, and fluvastatin have less muscle issue than simvastatin and atorvastatin. Some people go out there and get coenzyme Q to see if that will help their muscle pains. It doesn't work in randomized trials. It's a waste of your money. We do have a few patients who cannot tolerate any statin medications, but they still need to have their cholesterol lowered. There are other drugs that can be used to lower cholesterol and reduce your chances of heart attacks and strokes. They're nowhere near as good as statins, but they do work a little bit, and so they're useful for those patients. Well, let's finish up and look at the diet stuff. So remember that the diet portfolio is adding foods that lower LDL cholesterol. Plant stanols and sterols that you can purchase either as a capsule or by eating certain kinds of margarine. You may have seen Benecol margarine at Smith's. Is very effective. It'll lower your LDL cholesterol 6 to 10%. What is called soluble fiber, not diet fiber. So if you see diet fiber on the cereal box, it doesn't lower your cholesterol. Soluble fiber is different stuff that I'll show you. There are some cereals, like some of the cashew cereals have soluble fiber, and they'll tell you how much. That'll lower you 3 to 5%. A handful of nuts will lower you 3 to 5%. Soy protein, 3 to 5%. And so in the diet portfolio, we try to put that all together. How do you do it? You got to be a margarine eater for those plant stanols here. It's 2 tablespoons a day. Now, I could polish that off at one sitting and never blink an eyelash, but a lot of people aren't into margarine much. You can also get 2 capsules of Cholestoff at Walmart and take 2 capsules twice a day, and it would give you a 6 to 10% reduction. Where does soluble fiber come? Oat bran, beans, barley, okra, eggplant. I can't eat all of that stuff on a regular basis. It isn't going to happen. But Metamucil, good old Metamucil to keep those bowels going, a tablespoon twice a day does everything you need, about a 5 to 6% reduction. Almonds, walnuts, macadamia nuts are the best nuts, and unsalted handful. Remember, you don't want to lower cholesterol while you're causing hypertension. An unsalted handful a day. And if you combine these, we believe that most patients can get pretty close to a 15% reduction in their bad cholesterol. Who do I push this on? Patients who need a statin, who won't take a statin, or people who won't tolerate a statin. Then I go all out to try to change that diet. If they're on a statin and doing well, I think all of this is not needed. Do we really know how diet relates to coronary heart disease? Most of the studies of diet are based on observational, not randomized trials. Most of the studies look at surrogate endpoints. They look at cholesterol levels. They don't look at actual heart attacks and strokes. It is not proven that eating a diet high in saturated fat and high in cholesterol actually increases coronary heart disease. That is not proven. It is not proven that eating a diet low in saturated fat and low in cholesterol reduces coronary heart disease. We don't have data. We know it changes the lipids, the cholesterol levels, but we don't know that it prevents the disease. We know that statins prevent the disease. It is also proven that many people who eat a low-fat diet increase their intake of simple carbohydrates, and that strikingly increases your risk for obesity and type 2 diabetes. A good example is those fat-free gummy bears on the grocery aisle. They taste great, they don't have any fat, but it's diabetes and obesity. What about the popular diets that are out there? How well do they work on both weight loss and cardiovascular risk factors? Well, when they review all of the randomized trials that have compared Atkins and South Beach and Weight Watchers and zone diets, the average weight loss in those studies, 6 pounds, that's all it is. Despite millions of dollars spent on popular commercial diets, data are conflicting and insufficient to identify one popular diet as being more beneficial than the others. Is there no hope? No, there is hope. There is one diet, and it is called the Predimed diet. This is a Mediterranean diet, and this is a study in the Bible of Internal Medicine, which is the New England Journal of Internal Medicine. This is a randomized trial of 7,500 patients who were followed for 4 years. Half of the patients did the Mediterranean diet. Half of the patients went on to the standard low-fat diet, low saturated fat, low cholesterol. And at the end of 5 years, there was a 30% reduction in cardiovascular events with the Mediterranean diet. So what do you got to do that? You got to have 4 tablespoons a day of extra virgin olive oil. You got to have a handful of nuts 3 times a week. You got to have fresh fruits 3 servings a day. I don't do that in a week. Vegetables 2 servings a day. Fatty fish 3 servings a week. Beans and peas 3 servings a week. White turkey and chicken, replacing all red meat. Tomato, onion, olive oil sauces 2 servings a week. And if you want to hit the sauce, you can do it. You can do up to 7 glasses of wine a week. Yay. Yay. So, what shouldn't you be eating in this diet? Soda drinks, less than 1 a day. Commercial baked foods, goods and sweets, less than 3 times a week. Those margarines that I like, less than once a day. And red meat, less than once a day. So this is the only diet that has actually been proven in a good study to lower cardiovascular events. What about those omega-3s? There are 2 different kinds of omega-3s. There are the ones that are called alpha-linoleic omega-3s. Those are in plant-based foods. So those are in olive oil, soy oil, canola oil, walnuts, and flaxseed. The EPAs and the DHAs are in fatty fish, the ones listed here. Now, in an observational study, and those aren't very good, but in one observational study, they found that fatty fish once a week looked like it was a statin drug. Observational data, very weak. There is a randomized trial, though, that suggested that either 5 grams of cod liver oil a day, that's going to be burping fish all day, or 2 grams of omega-3 concentrate, also burping fish, did lower events by 15%. So if you want to burp fish, could work. Okay, so let's quit there.
Are there any questions? Dr. Stoltz?
Have you seen any studies that show that these statin drugs cause cancer?
So there is great data about statin drugs and cancer. And if you go back to those meta-analyses that have almost 200,000 patients in them, no excess risk of cancer was found. Now, there was a little bit of increased risk of dying from other things than heart disease, but you got to die from something, right? Total mortality in the studies is reduced just like cardiovascular mortality, just like heart attacks and strokes. All the mortalities are reduced.
You're not supposed to take grapefruit with statin. Why is that?
So grapefruit, and it requires a large amount of grapefruit juice, and the studies have suggested that it's somewhere between 12 and 24 to 36 ounces a day. I don't know if anybody does that much grapefruit juice for very long, but there's a chemical in grapefruit juice that prevents the statin drugs from being broken down in the liver. And so the blood levels of the statins go way up if you're eating or drinking a boatload of grapefruit juice. You're absolutely correct, but it's got to be a lot. I think it's not going to be a deal. But if you're somebody that's having 12 ounces of grapefruit juice every morning, probably got to make a choice.
Does the diet also, will it reduce or reverse the clogging of the artery?
So the question is, how do you reduce clogging in the arteries? Almost nothing reduces it very much.
Reverses it, yeah.
Reverses it or reduces it. You don't make it go back to baseline. What statin drugs do, and to a lesser extent diet, is they stabilize the plaques that are in the arteries. And what causes a heart attack is not progressive narrowing. It is instead a plaque ruptures. And when the plaque ruptures, it causes a blood clot immediately. And so what statins and to a lesser extent diet do is they stabilize the plaques and they prevent the plaques from rupturing. It's very hard though to see in the studies that there's any opening up of the lumen when you do statins or anything else.